All right, welcome everyone. If you're a med student prepping for your exams, then you have landed in the perfect spot. We are about to dive into 10 classic neurology cases. And look, the goal here isn't just to cram facts. It's about learning how to really think your way through these tricky clinical puzzles.
So here's the game plan. We're going to tackle these 10 cases by zeroing in on 3 core skills. These are the things neurologists do day in and day out. First, finding where the problem is, localizing the lesion. Second, figuring out what it could be. That's your differential. And third, deciding what to do right now, making those critical management calls. If you can get these 3 things down, you're not just going to pass your exams, you're going to crush them.
Okay, quick look at our roadmap. We'll start with localization, then hit the differential diagnosis challenge, move on to acute decisions, and then wrap it all up with a super high-yield summary at the end. Let's get started.
All right, Section 1, the art of localization. This is all about asking that one fundamental question: where is the lesion? Seriously, in neurology, before you can figure out what is wrong, you absolutely have to know where it's wrong. Every little sign is a breadcrumb leading you right to the spot.
Okay, let's jump right in with a puzzle. Picture this. A patient walks in. They've got a drooping eyelid and a big dilated pupil on one side. But the weakness, it's on the other side of their body. See that? Those are crossed signs, and they are a giant flashing neon sign pointing you where to look. So just think for a second. Where in the brain could a single problem cause that? A cranial nerve issue on one side and a body issue on the other?
And boom, that's a brainstem lesion. That's the only place it can be. Specifically, we're talking about the midbrain. This is your classic Weber syndrome. So the take-home message here, the big one, is this. When you see a cranial nerve palsy on one side and motor signs, like weakness, on the opposite side, your brain needs to immediately just shout, brainstem.
Okay, let's try another one. Same principle. This time you see a small pupil, a droopy eyelid. That's classic Horner syndrome, right? But this patient also has a hoarse voice and can't swallow properly. Well, that points right to the vagus nerve. So you put it all together, and this specific cluster doesn't point to the midbrain anymore. Nope. This combination tells you the lesion is much lower in the lateral medulla. See? Different symptoms, different spot, but the exact same logic.
All right, let's switch gears a bit and talk about another huge localizing clue: muscle tone. This is a big one for exams. On one hand, you've got cerebellar lesions. A patient with a problem in their cerebellum, they're going to have reduced muscle tone. We call it hypotonia. Think kind of floppy, clumsy. But on the other hand, if you have an upper motor neuron lesion, say in the pyramidal tracts, you get the total opposite. You get spasticity, increased tone. These are night and day. Nail this distinction, and that's an easy point on your test.
Okay, pupillary reflexes. I know these can seem confusing, but trust me, it's just pure logic. Let's break it down. Step 1, you shine a light in the affected eye, and neither pupil constricts. What does that mean? It means the light-in signal never got to the brain. That's a sensory problem, right? An optic nerve lesion? Okay, step 2. Now you shine the light in the good eye. The good eye constricts, but the bad eye still doesn't. Aha! So the signal got in this time, but the constrict command couldn't get out to the bad eye. That's a motor problem, a third nerve lesion. So this poor patient has both, which tells us the problem has to be somewhere they're both running together, like in the orbit.
Okay, we've had some good practice on finding the where. Now it's time to move on to the what. Section 2 is the differential diagnosis challenge. Basically, what could this be? We're going to look at some cases that are notorious for looking alike. So here's a classic one. A patient tells you they had this weird visual thing, shimmering lights that kind of slowly spread across their vision over a few minutes. Now, a lot of people's first instinct is TIA, right? A mini stroke. But hold on, is it really? The biggest clue is right there in the description, the timing, how it spreads. And this really breaks it down for us. Look, a TIA, a vascular problem, is sudden. It's like a switch being flipped. Bam, vision is gone. But a migraine aura, that's totally different. It's caused by this slow-moving electrical wave in the brain. We call it cortical spreading depression. And because it's a slow wave, the symptoms, well, they spread slowly too, over minutes. It's all about the timing. So this is the key concept. You have got to burn this into your brain for the exam. If you read a question that describes a visual disturbance that spreads gradually, that marches or expands over minutes, the answer is migraine aura, period. And that's true even if they never mention a headache. This little nugget right here is a total game changer on test day.
Okay, vertigo. This is another one that can be a real headache, no pun intended. Lots of things cause it, but you know what your secret weapon is? Hearing loss. Ask about the hearing. With Meniere's disease, you get these crazy, recurrent episodes of spinning, sure, but you also get hearing loss that gets worse over time. Compare that to something like vestibular neuronitis. That's all vertigo, no hearing loss. Your hearing is totally fine. It's a huge differentiator.
And this is it. This is the classic board question triad. You see these three things together: recurrent vertigo, progressive hearing loss, and tinnitus, that ringing in the ears. If you see that combo, your hand should automatically be marking Meniere's disease. It's a pattern you just have to know.
Now let's talk about Wernicke's encephalopathy and some common exam traps. Look, knowing the classic triad, confusion, eye movement problems, that's great. But what's even more high yield is knowing what Wernicke's is not. It's a thiamine deficiency problem affecting the brainstem. It does not cause neck stiffness, that's meningitis. It does not cause big seizures, that's more like alcohol withdrawal. And it does not cause upper motor neuron signs. If you see any of those things, you've got to be thinking about something else going on.
Okay, we've figured out where it is and what it is. Now for maybe the most important question of all: what do I do now? This next section is all about acute decisions in management. We're talking about those crucial first steps that can make all the difference.
So let's start with a big one. A patient comes in with a sudden onset weakness on one side, classic stroke. Your first thought is probably, get him some aspirin, right? Bust that clot. But is that the right move? Is that what you do immediately?
The answer is a hard no. Absolutely not. And this is completely non-negotiable. The first thing you do, the only first thing you do, is get an immediate non-contrast CT of the brain. You do not pass go, you do not give any medicine, you get the scan. This is basically the golden rule of acute stroke care. And here's the really simple reason why. Not all strokes are from clots. Some are from bleeding into the brain, a hemorrhagic stroke. Now, can you imagine giving a blood thinner, like aspirin, to someone who's actively bleeding in their head? It would be an absolute disaster. And you can't tell the difference just by looking at them. So you have to get that CT. The first and most important question is there blood?
Okay, here's another one where you have to act fast. An elderly patient comes in, they have a new kind of headache, and now they're having vision problems. This should be screaming temporal arteritis at you. And the key word here is urgent. Yes, you'll order an ESR blood test, but you give high-dose steroids right away. You don't even wait for the biopsy results. Why? Because the vision loss can become permanent in a matter of hours. You have to treat first and confirm later.
So what about long-term prevention? Imagine a patient had a TIA. You do a scan and you find their carotid artery is, say, 25% blocked. Should you be calling the surgeons? Well, take a look. The evidence is super clear on this. For mild stenosis like that, there's no benefit to surgery. The right answer is medical management. Put them on aspirin. You only start thinking about surgery for much more severe blockages in patients who are having symptoms.
All right, we've covered a ton of ground. Now it's time to bring it all home. Section 4, your high-yield summary. Let's do a quick-fire review to lock all this in.
Okay, let's boil it all down. Wernicke's, confusion and eye signs, no UMN signs. Acute stroke, CT before you do anything else. You see crossed signs, cranial nerve on one side, body weakness on the other. That's a brainstem lesion. Cerebellar problem, that's hypotonia, not spasticity. A slowly spreading visual aura, that's a migraine, not a TIA. An elderly person with a new headache and vision loss, get an ESR and start steroids immediately. See that combo of vertigo and hearing loss? That's Meniere's. Honestly, this slide is your whole review. Pause it, take a screenshot, whatever you need to do. This is pure gold.
So, let's wrap this up with one final thought. Neurology isn't really about memorizing 1,000 different diseases. It's about recognizing patterns. Every patient presentation is a pattern waiting to be solved. We've gone through 10 of the big ones today. The real question is, which pattern are you going to see next? Good luck out there.